Good morning or good afternoon. My name is Natasha Telusca. I am a pain physician at Stanford University and hospitals. For the pain management lecture series, I will be covering antidepressants and anticonvulsants for the management of neuropathic pain. At the end of this lecture, I hope that you will be able to discuss the mechanisms and effects of gabapentinoids, anticonvulsants, and antidepressant drugs in neuropathic pain. Be able to identify medications that have evidence for the treatment of different types of neuropathic pain, and be able to discuss the contraindications and side effects of these medications. The definition of neuropathic pain. According to the International Association for the Study of Pain, neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. Neuropathic pain is very common. You may know of someone, either a family member, a friend, parent, or grandparent who suffers from neuropathic pain. The prevalence ranges between 6.9% and 10% of the general population. It is a major contributor to the global burden of disease. I have many patients in my clinic who suffer greatly from neuropathic pain. They've tried different classes of medications and different interventions with no significant improvement, and they live with neuropathic pain daily. Etiology of neuropathic pain: nerve damage, compression, trauma, surgical amputations, diabetes, vascular or autoimmune conditions, cancer, chemotherapy, viral infections such as HIV, alcohol and other toxin exposure, hereditary disease, and spinal cord injury. Symptoms of neuropathic pain. Patients may present with burning, tingling sensations. They may report electrical shock-like pain. They may have paresthesias, numbness, allodynia, which is the painful sensations to harmless stimuli. They may also have hyperalgesia, which is increased sensitivity to painful sensations. Types of neuropathic pain: postherpetic neuralgia, complex regional pain syndrome, painful diabetic neuropathy, HIV-associated neuropathy, peripheral nerve injury, alcohol-induced neuropathy, drug-induced neuropathy, amputation, stump and phantom limb pain, cancers, and trigeminal neuralgia. In my clinic, we see a lot of patients with painful diabetic neuropathy, peripheral nerve injury. We have some people with trigeminal neuralgia and complex regional pain syndrome, as well as postherpetic neuralgia. Anticonvulsants and antidepressants are effective in various neuropathic pain conditions. They are the first line of treatment for neuropathic pain. It is important to note that many of the anticonvulsants and antidepressants that we use for neuropathic pain are being used off-labeled. The following slide discussed some of the FDA-approved medications for neuropathic pain. For diabetic peripheral neuropathy, Nucynta ER is approved. We will not cover these drugs. Lyrica, Cymbalta. For postherpetic neuralgia, Lyrica, Neurontin, Grelease, gabapentin, Inocabile, transdermal lidocaine patch, and capsaicin 8% are approved for postherpetic neuralgia. For trigeminal neuralgia, Tegretol, also known as Carbamazepine, is approved for trigeminal neuralgia. So we'll talk about the gabapentinoids, which include Lyrica and Neurontin. Pharmacodynamics of gabapentinoids. They bind to the alpha-2 delta subunits of the voltage-dependent calcium channels. These calcium channels are localized in the presynaptic terminals where they control neurotransmitter release. When they are bound, they cause or decrease the release of glutamate, norepinephrine, and substance P. These neurotransmitters are involved in the pain processing. So the above mechanism confer its anti-epileptic, analgesic, and sedative effects. It is important to note that Lyrica or Neurontin do not interact with GABA-aminobutyric acid receptors. Gabapentin pharmacokinetics. This medication uses a saturable L-amino acid transport system that is found in the upper gastrointestinal tract for absorption. It has a non-linear absorption. That's the reason the maximum dose of Neurontin daily dose is about 3,600 milligrams, because bioavailability is not dose proportional. Elimination is through the kidneys. It has a first order kinetic elimination. It's very important to adjust the dose in patients with kidney disease. The half-life is about 5 to 7 hours. Patients typically take this medication 3 times a day. But I have patients who find it to be more effective when they take it 4 times a day, so about every 6 hours. Gabapentin has no documented long-term toxicity, active metabolites, hepatic enzyme induction, or major drug interactions. There are 2 extended release forms of gabapentin. The first one is release. It was the first extended release medication. It uses a gastroretentive formulation where it continuously delivers the medication at the optimal site of absorption in the upper small intestine over 8 to 10 hours. This is a 1 time a day dosing medication. The next one is gabapentin inocabil horizont. It is an extended release prodrug. Absorption through a high capacity transport system found throughout the intestine. It has a rapid hydrolysis to gabapentin. It has a twice daily dosing schedule. Pregabalin pharmacokinetics. Unlike gabapentin, it has a rapid absorption following oral administration. It has a high bioavailability. It has a linear absorption and is very potent. Elimination is through the kidneys. Again, it's very important to adjust the dose in patients with kidney disease. The half-life is about 5 to 6 hours. The typical dosing schedule is about twice daily, but I have many patients who find that it's much more effective for them when they take it 3 times a day. Warning, precautions, and adverse effects. It is very important to educate your patient about the side effects of these medications. The common side effects include sleepiness, dizziness, dry mouth, fatigue, peripheral edema, and weight gain. I like to emphasize the weight gain part. It can be anywhere from 5 to 30 pounds. So it's very important to educate your patient about the potential for weight gain. I will try to avoid this medication on patients who are already obese. And a lot of patients are fearful of gaining weight. Sometimes they will refuse to take Lyrica or gabapentin because of the fear of weight gain. I will educate them, ask them to monitor their weight weekly. If they start gaining weight, then we can discontinue the medication. It's also important to monitor your patient for depression, suicidal thoughts, and other mood changes, which can occur with Lyrica and gabapentin. There's post-marketing reports of angioedema and hypersensitivity with Pregabalin. The next medication we'll talk about is Carbamazepine tegretol. It inhibits voltage-gated sodium channels. It potentiates GABA receptors. It is FDA approved to treat trigeminal neuralgia. Dosage ranges from 300 milligrams to 1,000 milligrams per day and divided doses twice daily. Carbamazepine is metabolized by the cytochrome P450 system. It is an inducer of the cytochrome P450 system. It has numerous drug interactions, oral contraceptives, warfarin, and other anticonvulsants. Again, it's important to review a patient medication list if they're taking oral contraceptive, warfarin, other anticonvulsant. This may not be the best medication for them. Warning, precautions, and adverse events. The common side effects include sedation, dizziness, nausea, vomiting, rash, liver damage, hyponatremia, memory problems, tremor, and ataxia. The rare serious side effects are leukopenia, aplastic anemia, allergic rash, systemic lupus erythematosus, liver toxicity, Stevens-Johnson syndrome, toxic epidermal necrolysis. Also important to note that patients of East and Southeast Asia with HLA-B1502 allele are at significantly higher risk of developing Stevens-Johnson syndrome and toxic epidermal necrolysis. Before I start patients on this medication, it's important to get a baseline blood count, CBC, a serum sodium, and liver function test. And it's also important to repeat these tests after several weeks of starting the medication to detect any complications. The next medication is Oxcarbazepine, Trileptal. This is a keto analog of Carbamazepine. It's a prodrug. It has an active metabolite, 10-aminodroxy. It blocks voltage-gated sodium channels. It's used for epilepsy and trigeminal neuralgia. Dosage ranges from 600 to 1200 milligrams a day, and divided doses BID. From my experience, I haven't found Trileptal or Tegretol to be effective in neuropathic pain. I typically use it as a last resort for patients who failed Neurontin, Gabapentin, Lyrica, and TCAs. There was a Cochrane database systemic review published in 2017. Again, they found limited evidence for its effectiveness in peripheral direct neuropathy and other forms of neuropathic pain. Again, these medications are good for trigeminal neuralgia, but I haven't found them to be effective in treating other neuropathic pain. But if my patients failed the common anti-neuropathic agents, I will offer them a trial of Trileptal or Tegretol. Oxcarbazepine has less adverse effects and drug interaction than carbamazepine. Common side effects include sedation, dizziness, nausea, vomiting, diplopia, memory problems, ataxia, and hyponatremia. I underline hyponatremia because it is very important to get a baseline sodium level before you start this medication and to check the level within a few weeks after starting the medication because it can drop the sodium level significantly. Rare serious side effects include leukopenia, allergic rash, toxic epidermal necrolysis, and Stevens-Johnson syndrome. Again, you must educate your patient about these potential common and rare serious side effects. And don't forget about the sodium level. Lamotrigine, Lamictal. This medication is used for seizures and bipolar disorder. It is a sodium channel blocker. I've never prescribed this for pain. I do have colleagues in my clinic who use it for migraines. There's a lack of evidence for using this medication for neuropathic pain. I would only consider this medication in patients who have failed other treatments. Side effects, common one, include nausea, vomiting, sedation, drowsiness, dizziness, headaches, malaise, visual disturbance, and ataxia. The most frequent side effect is a skin rash. It can be severe rash, like a Stevens-Johnson syndrome. So again, it's important to educate the patients about the potential of a rash with Lamotrigine. The rash can be minimized by keeping the starting dose at as low as 25 milligrams per day. Valproic acid inhibits Lamotrigine metabolism. Oral contraceptive induce Lamotrigine metabolism. Topiramate, it is one of my favorite medications. I'm also a board certified obesity management specialist. So I like Topiramate because of the side effects of weight loss. It blocks activity-dependent voltage-gated sodium channel. It enhances the action of GABA receptor. It inhibits L-type voltage-gated calcium channels. Presynaptically reduce glutamate release. This medication is approved for the treatment of epilepsy and as a prophylaxis for migraine. It's also approved for treatment of obesity. Again, if I have a patient who's obese, I'm trying to manage their pain, I will add Topiramate with the goal really to help them to lose weight. I've had great success with this medication for weight loss. But as far as neuropathic pain, it's not effective for neuropathic pain. No significant therapeutic efficacy even at high dose, 200 to 400 milligrams per day. So this may not be the first line of treatment for neuropathic pain, but for migraine, it's a good medication. If your patients have neuropathic pain and they also have high BMI, it might be worth a trial for them with the goal really to help them lose some weight. Side effects include dizziness, fatigue, nausea, poor concentration, and weight loss. Again, most people like the weight loss part. They may have the peri-oral and digital paresthesia. But on the other hand, if you have a patient who's underweight, this is not the medication for this patient. There are reports of reversible anorgasmia in men and women. Nephrolithiasis and glaucoma. It is very important to do a thorough history of your patient. If they have a history of kidney stone or glaucoma, this medication is not the medication for them. I have a young lady who has no history of glaucoma. I started her on this medication a couple months ago for migraine prevention. And on a Friday evening, she called me reporting blurry vision, right eye pain. I knew right away that she may have an increase in her intraocular pressure. I sent her to the ED immediately. They checked her eyes, measured the pressure. It was elevated. So she discontinued the medication. And also there's teratogenic effects. So it's important to educate your patients who are trying to conceive or are childbearing age to use contraception. And if they're trying to conceive, this is not the medication for them. Next medication is Mexiletine. This medication is an oral analog of lidocaine. It is a sodium channel antagonist. It was designed to be a cardiac antiarrhythmic drug, but we found that it's been helpful in neuropathic pain, fibromyalgia, headache, and erythromelalgia. It is metabolized and delivered via the cytochrome P450 system, CP2D6, and CP1A2. Inhibitors of CP2D6 include duloxetine, bupropion, fluoxetine, and citalopram. CYP1A2 include verapamil, fluvoxamine, and ciprofloxacin. Before we start someone on Mexiletine in our clinic, we typically do a trial of IV lidocaine, either in the hospital or as an outpatient. And if they receive significant benefit and pain relief from the IV lidocaine, then we'll offer them a trial of oral Mexiletine. Before you start Mexiletine, you need an EKG to measure the QTC interval. We start the medication at 150 milligrams daily and titrate up every 2 weeks to 150 milligrams 3 times a day as tolerated. So you have to monitor your patient very carefully because this medication has a very narrow therapeutic index. It has been reported to be effective in diabetic neuropathy, alcoholic neuropathy, peripheral nerve injury, and thalamic pain. Common side effects include dizziness, tremor, incoordination, visual disturbance, paresthesia, nausea, and heartburn. It's important to advise your patient to take Mexiletine with food to reduce the incidence of nausea or heartburn. Mexiletine should not be given to patients receiving IV lidocaine because it displaces lidocaine from binding sites. In our clinics, we have many patients who take oral Mexiletine, and also they come every few months for IV lidocaine infusion. So we typically advise them to stop the Mexiletine the day before they receive the IV lidocaine. The next class is the antidepressants. The precise mechanisms are not clear. We don't really know how these work. The proposed mechanisms are based on animal studies. We know that norepinephrine is important for inhibition of neuropathic pain. With norepinephrine reuptake, you have inhibition of neuropathic pain through the alpha-2 adrenergic receptors in the dorsal horn of the spinal cord. These alpha-2 adrenergic receptors are coupled to the inhibitory G protein, which inhibits the presynaptic voltage gated calcium channels in the dorsal horn of the spinal cord that inhibits the release of excitatory neurotransmitters from primary efferent fibers. Norepinephrine also acts on the locus coeruleus and improves the function of the impaired descending noradrenergic inhibitory system. Serotonin and dopamine may reinforce the noradrenergic inhibitory system. TCAs, tricyclic antidepressants. The secondary means are nortriptyline, desipramine, protriptyline, amoxicillin. Tertiary means are amitriptyline, imipramine, trimipramine, clomipramine, and doxepin. Desipramine is a metabolite of imipramine. Amitriptyline metabolizes into a secondary amine, nortriptyline. Doxepin is the most anticholinergic. It has a topical formulation approved for itching. It is a potent sodium blocker as well. So TCA mechanism, it inhibits the reuptake of serotonin and norepinephrine. As I mentioned earlier, norepinephrine is extremely important for inhibiting neuropathic pain. By inhibiting the reuptake process, TCAs enhance the descending noradrenergic and serotonergic inhibitory pathways. The antineuralgic properties appear to be independent of the antidepressant effects of these drugs. TCAs also block histaminic, cholinergic, and alpha-1 adrenergic receptor sites. The tertiary means inhibit serotonin to a greater degree than norepinephrine. The secondary means have more pronounced effects on norepinephrine and less sedative side effects. The more selective TCAs cause few anticholinergic effects and less sedation. Side effects include dry mouth, constipation, dizziness, blurry vision, drowsiness, orthostatic hypotension, sedation, urinary retention, sweating, headache, palpitation, irritability, ataxia, arrhythmia, and weight gain. It is important to educate your patient about the potential for these side effects. Cautions: TCA should be used cautiously in patients at risk for suicide or accidental death from overdose. I personally tend to avoid TCA in patients who have a history of drug overdose or have tried to commit suicide in the past and are very depressed. Avoid TCAs in patients who have ischemic heart disease or increased risk of sudden cardiac death. TCAs may cause QT prolongation, therefore an EKG is recommended before you start a patient at a TCA. The secondary means nortriptyline and desipramine are my preferred TCAs because I find that patients tolerate them much better. Desipramine overdose is more likely to result in death than overdose with other tricyclic antidepressants. The FDA even issued a warning. The FDA says, use extreme caution when prescribing the antidepressant desipramine in patients with a family history of dysrhythmias or sudden cardiac death. The next class is the serotonin norepinephrine reuptake inhibitors, SNRIs. They include venlafaxine, duloxetine, desvenlafaxine, and Milnacipran. They are used for depression, anxiety disorders, obsessive compulsive disorders, attention deficit disorders, fibromyalgia, musculoskeletal, and neuropathic pain. Again, as mentioned before, the mechanism is serotonin and norepinephrine reuptake inhibition. The one I use the most is Cymbalta, duloxetine. It is FDA approved for the treatment of painful diabetic polyneuropathy, fibromyalgia, and chronic musculoskeletal pain. I like it because it has minimal cognitive depression. It treats comorbid depression. It's weight neutral, but you need to note that it is an inhibitor of the cytochrome P2D6. It inhibits its own metabolism within the first 48 hours of its initiation and the conversion of codeine to its active form, morphine. So be mindful of that. The most common side effect is nausea. That's what I see in my practice. That's the most common reason why patients stop taking this medication. I typically educate the patient about the potential for the nausea, advise them to take it at night time with food. And the nausea tends to get better over time. And sometimes they can't tolerate it because of the nausea, then I have to switch them to something else. So do not add Cymbalta to an SSRIs. If you have a patient who's taking an SSRIs, you want to switch into Cymbalta, it's important that you have them discuss it with their primary treating physician or psychiatrist, and they can use it instead of the SSRIs. Avoid using that with tramadol because there's concern for serotonin syndrome. I've never seen it, but I do have patients who are taking both Cymbalta and tramadol. I educate my patients about the potential for this syndrome. It may cause orthostasis. Avoid abrupt discontinuation due to withdrawal symptoms. It's not appropriate in patients with severe liver and kidney disease. Venlafaxine Effexor is a mixed action antidepressant. It inhibits the synaptic reuptake of serotonin, norepinephrine, and dopamine. It predominantly inhibits serotonin reuptake at low doses and norepinephrine reuptake at higher doses. It is extensively metabolized by the liver to its active metabolite, O-desmethylvenlafaxine. There was a study published in 2017 by Iyer where they look at Effexor and neuropathic pain. They found that it was well tolerated generally, and when compared with placebo, venlafaxine demonstrated notable reduction in neuropathic pain. Common effects include sustained hypertension. So if you have a patient who have uncontrolled hypertension, this may not be the drug for them. Other side effects include mydriasis, anxiety, dizziness, nausea, dry mouth, nervousness, insomnia, and weight loss. Patient can also have severe sexual adverse effects. So it's important to educate your patient about these side effects. The next thing, cautions, again, avoid abrupt cessation of the drug because it can lead to unpleasant withdrawal symptoms. Monoamine inhibitors, you should not use that with patient taking Effexor. Patient with glaucoma, liver disease, or renal impairment, be careful. And the dose should be reduced in patients with liver and kidney disease. The next one is Milnacipran, known as Savella. It is FDA approved for the treatment of fibromyalgia. I've never prescribed this medication for neuropathic pain. I've considered it for fibromyalgia. There's no evidence to support its usage for neuropathic pain. Use of milnacipran is contraindicated with concomitant or recent monoamine oxidase inhibitor use, uncontrolled narrow angle glaucoma, and in children or adolescents. Tapering is necessary to avoid withdrawal-related adverse effects. Common adverse effects include nausea and vomiting, headache, dizziness, insomnia, and palpitations. So what do you do when you start a patient on antidepressants? You have to monitor them. You have to educate them. Sometimes patient will stop the medication after a few days because it's not working. So it's important to tell them, listen, this medication is not going to work for a good 6 to 8 weeks. You may experience some improved sleep immediately within a few days or so. But as far as pain relief, it may take several weeks because I typically start them very slow, low doses and titrate the medications to a dose that they can tolerate over 6 to 8 weeks. If after being on a tolerable dose for 6 to 8 weeks, no relief, then that's when I will consider stopping the medication and choose a different medication. If you're using it for depression, again, it takes even longer, 6 to 8 weeks. For all my patients who are over 40 years of age, I typically get a baseline EKG. Again, monitor your patient for weight gain, sometimes more often with TCAs than with the newer SNRIs. Educate them about sexual dysfunction, monitor them for sexual dysfunction. They can have anorgasmia, delayed ejaculation, decreased libido, again, your common sedation, fatigue, anxiety, and insomnia. Just to do a quick summary here, gabapentinoids, TCAs, and SNRIs are first line of drug therapy for neuropathic pain. For gabapentin, you have an average dose of 150 to 600 milligrams per day. Gabapentin, 300 to 3,600 milligrams per day. Useful for painful diabetic neuropathy, post-operative neuralgia, central neuropathic pain, spinal cord injury, phantom limb syndrome. For TCA, amitriptyline is one example, 10 milligrams to 150 milligrams per day. My preferred are disipramines and nortriptyline, useful for painful neuropathy, nerve injury, post-operative neuralgia, and spinal cord injury. As far as the SNRIs, I use Cymbalta mostly. The dose is 20 to 120 milligrams per day. I find it to be very effective. It's FDA approved for the management of diabetic neuropathy. Venlafaxine, the dose 120 to 225 milligrams per day. Anticonvulsant, Carbamazepine, 200 to 400 a day. Oxcarbazepine, 300 to 600 milligrams per day. Very useful for trigeminal neuralgia. Well, I hope you enjoyed this lecture. Have a good day.